This week in lab, we'll be reading through Exercise 31, Conduction System of the Heart, and completing Exercise 33, Cardiovascular Physiology. The ability of cardiac muscle to beat is intrinsic, meaning it does not depend on impulses from the nervous system to initiate its contraction, and will continue to contract rhythmically even if all nerve connections are severed. The nervous system affects the heart by making it beat faster or slower, but the nervous system does not generate the electrical impulses that cause contraction of the heart muscle. The intrinsic conduction system ensures that the heart muscle depolarizes in an orderly and sequential manner, from atria to ventricles, and that the heart beats as a coordinated unit. As you know from our previous studies in histology, the heart consists of cardiac muscle cells. There are two types of cardiac muscle cells: cardiomyocytes, which contract, and specialized cardiac muscle cells called cardiac pacemaker cells. Cardiac pacemaker cells generate electrical impulses called action potentials. The sinoatrial node is made up of cardiac pacemaker cells and initiates all spontaneous action potentials. Because of this, the SA node is called the pacemaker of the heart. Action potentials are propagated along cardiomyocytes throughout the rest of the heart, causing synchronized contraction of the atria first, followed by the ventricles. It's important to understand that action potentials are caused by the depolarization of cardiac muscle cells. Our cardiac muscle cells are more negatively charged on the inside than the cell's exterior. In other words, the cells are polarized. This difference in charge between the inside and outside of the cells is called the cell's membrane potential. The membrane potential of cardiac muscle cells when they're at rest, not contracting, is around -70 to -90 millivolts. In the process of depolarization, the negative internal charge of the cell temporarily becomes more positive. The membrane potential slowly becomes more positive until it reaches the threshold level, around -40 millivolts. Once the membrane potential hits this threshold level, an action potential is produced. The action potential passes along the cell membrane, causing the cell to contract. Because all cardiac muscle cells are linked together by gap junctions, action potentials can rapidly pass from one cell to the next, causing all atrial cells to contract together, followed by the contraction of all ventricular cells. Overall, remember that in order for action potentials to travel throughout the heart and contraction to occur, cardiac muscle cells must undergo temporary depolarization. When you think of depolarization, think of contraction. The wave of depolarization follows a specific pathway through the heart. The sinoatrial node, or SA node, in the right atrium spontaneously generates between 60 and 100 impulses per minute under normal conditions. The impulse spreads through the right and left atria. When it reaches the atrioventricular node, the impulse pauses for 1/10 of a second. The delay allows the atria to finish contracting before the ventricles begin to contract. It's important to note that the impulse is able to freely spread throughout the atria, but can only spread to the ventricles via the tract between the AV node and the AV bundle. Once through the AV node, the impulse passes rapidly through the rest of the system, to the AV bundle, the bundle branches through the interventricular septum, and finally to the Purkinje fibers, depolarizing the cardiac cells and causing contraction of the ventricles. This intrinsic conduction system ensures that the cardiac muscle cells of the heart depolarize in an orderly and sequential manner, from atria to ventricles, allowing the heart to beat as a coordinated unit. The conduction of impulses through the heart generates electrical currents that can be detected and recorded with an instrument called an electrocardiogram, or EKG. A typical EKG has 3 obvious waves, or deflections: the P wave, the QRS complex, and the T wave. These waves are visual representations of the depolarization and repolarization of the heart's atria and ventricles. Atrial depolarization, initiated by the SA node, causes the P wave. With atrial depolarization complete, the impulse is delayed at the AV node. Once through the AV node, the impulse passes rapidly through the rest of the heart. Ventricular depolarization begins at the apex, causing the QRS complex. During this time, atrial repolarization also occurs. Ventricular depolarization is complete, and ventricular repolarization begins at the apex, causing the T wave. Abnormalities in the deflection waves and changes in their timing are useful in detecting a myocardial infarction, which is a heart attack, or arrhythmias suggesting problems with the conduction system of the heart. For example, an ST segment elevated from baseline is a possible indicator of myocardial infarction. In a healthy heart, the two atria contract simultaneously. As the atria begin to relax, the ventricles contract simultaneously. The terms systole and diastole refer to this contraction and relaxation, respectively. The cardiac cycle is equivalent to one complete heartbeat, during which both atria and ventricles contract and then relax. Atrial contraction occupies the first tenth of a second, while ventricular contraction occupies about 0.3 seconds. The remaining 0.4 seconds is a period of total heart relaxation, called the quiescent period. Not only are there measurable changes in electrical impulses throughout the cardiac cycle that we discussed earlier, there are changes in blood volume and pressure within the heart. Two main events control the movement of blood through the heart: the contraction and relaxation of the atria and ventricles, and the opening and closing of valves. The opening and closing of valves are entirely dependent on pressure changes within the heart chambers. When atrial pressure is greater than ventricular pressure, the AV valves, tri- and bicuspid valves, are forced open and blood flows passively into the atria and on through to the ventricles. At this time, both the atria and ventricles are experiencing diastole. They are at rest. The atria then contract, atrial systole, to push the rest of the blood through the AV valves and complete the filling of the ventricles. Ventricular diastole, relaxation, ends. The contraction of the ventricles, ventricular systole, begins, increasing ventricular pressure and causing the AV valves to slam shut. The slamming shut of the AV valves causes the first heart sound, the lub, in the normal lub-dub sequence. Ventricular pressure continues to rise. When the pressure within the ventricles exceeds the pressure in the great vessels, the aorta and pulmonary artery, the semilunar valves open, and blood is ejected through the pulmonary valve to the lungs, and the aortic valve to be delivered to the rest of the body. The ventricles relax, ventricular diastole, decreasing the pressure in the ventricles. This decrease in pressure causes the semilunar valves to slam shut, producing the second heart sound, the dub in the normal lub-dub sequence. As you can see, pressure changes in the heart control the opening and closing of the AV and semilunar valves, and result in the lub-dub that we hear when auscultating heart sounds. For this reason, abnormal heart sounds, called murmurs, often indicate problems with heart valves. In valves that don't close tightly, closure is followed by a swishing sound due to the backflow of blood, or regurgitation. High-pitched screeching sounds are associated with blood flowing through constricted valves. In addition to heart sounds, blood pressure is a vital indicator of heart health. Blood pressure is generally measured in the arteries with a sphygmomanometer, commonly called a blood pressure cuff. Blood pressure is taken via two readings: the systolic pressure, which is the pressure in the arteries at peak ventricular contraction, and the diastolic pressure, which is the pressure in the arteries during ventricular relaxation. Blood pressures are reported in millimeters of mercury, with systolic pressure appearing first. For example, this blood pressure translates to 120/80, with a systolic pressure of 120 millimeters of mercury and a diastolic pressure of 80 millimeters of mercury. Normal blood pressure can vary considerably from person to person. According to the American Heart Association, normal blood pressure is around 120/80. When discussing the cardiac cycle, we've learned that we must understand depolarization of cardiac muscle cells and the resulting action potentials that lead to the contraction of the atria and ventricles. We also must take into consideration changes in blood pressure, causing the opening and closing of heart valves, which produce heart sounds. We've learned that we can measure and interpret the various events of the cardiac cycle with an EKG by auscultating heart sounds, taking a pulse, and measuring blood pressure with a sphygmomanometer. A helpful summary of events occurring in the heart during the cardiac cycle can be found in exercise 33, tying together the EKG, heart sounds, blood pressure, and ventricular volume. When studying the events of the cardiac cycle, it's also helpful to remember that depolarization leads to contraction, atrial and ventricular systole, while repolarization is associated with relaxation, or atrial and ventricular diastole. In lab this week, we'll be completing exercise 33, Human Cardiovascular Physiology. Before coming to lab this week, read through exercise 31, Conduction System of the Heart, and take your pre-lab Canvas quiz the day before your scheduled lab. As always, reach out to your lab instructor if you have any questions or concerns.